Please remember to speak loudly and clearly into the microscope for the benefit of those who are calling in. Thank you.
Can you please give the right talk? There we go. On behalf of my colleagues at the Johns Hopkins University, thank you so much for this opportunity to present our interesting findings. I'll present the abstract entitled Encouraging Outcomes in Older Patients Following Non-Myeloablative Haploidentical Bone Marrow Transplant with High-Dose Post-Transplantation Cyclophosphamide. Allogeneic bone marrow transplant is potentially a curative for many patients with poor-risk hematologic malignancies. However, there are many obstacles to success. First, many patients lack a fully HLA-matched donor. Only 1 out of 4 siblings will be an HLA match. 50% chance at best of finding an unrelated match in the registry. And further, in African Americans and in ethnic minorities, there is a much more limited chance of finding an unrelated matched donor. Additionally, it can take months, on average about 4 months, to coordinate an unrelated donor bone marrow transplant. So in patients who have very advanced, rapidly progressive hematologic malignancies, this may not be a feasible time frame. But almost every patient has at least one haploidentical relative. Parents and biological children are, by definition, haploidentical, and patients will also have potentially haploidentical siblings. But until recently, haploidentical bone marrow transplant has carried excessive risk, including excess risks of graft versus host disease, graft rejection, and overall transplant-related death. Furthermore, hematologic malignancies disproportionately affect older patients who then go on to suffer higher risks of graft versus host disease and of end organ toxicity. However, there have been recent significant improvements in how we perform these half-matched transplants. And the regimen that our program is based upon is the use of high doses of cyclophosphamide after the transplant to help prevent graft versus host disease and graft rejection. Here is the general schema where patients receive reduced intensity conditioning, followed by a T-cell replete bone marrow infusion, followed by 2 doses of cyclophosphamide after the transplant, and then additional immunosuppressives. This is a major advance, and we have shown through the BMT-CTN, that's the clinical trial network, that with this approach, reduced intensity conditioning related half-matched transplants are safe and effective. Furthermore, at Johns Hopkins, we do this in a specialized outpatient department. So the rationale for our study is that post-transplantation cyclophosphamide significantly lessens the risk of half-matched transplants, yet there are very few data on haploidentical bone marrow transplant in older patients. So the objective of this study was to evaluate the impact of older patient age on outcomes of reduced intensity related haploidentical bone marrow transplant with post-transplantation cyclophosphamide. We retrospectively evaluated patients aged 50 to 75 years who received this type of transplant at Johns Hopkins for hematologic malignancies, with the transplant dates ranging from the year 2000 up through March of 2013. Patients needed to have a haploidentical first degree or half-sibling donor, and for this analysis, no prior allogeneic bone marrow transplant was permitted. Here are the patient characteristics. 273 transplant recipients were included in this analysis with a minimum age of 50. This included 154 patients who were aged at least 60, with a breakdown of 127 patients in their 60s and 27 patients who were aged 70 to 75 years at the time of transplant. The patients were relatively uniformly treated. Diagnoses are shown, with the majority of patients having either lymphoma, acute leukemia, or myelodysplastic syndrome. Notably, 15% of these patients had had a prior autologous bone marrow transplant. Over half of the patients were considered to have a high-risk comorbidity index, and the majority of patients had an at least intermediate risk disease risk index. Here are the results of our cohort overall with 273 patients. Notable findings are as follows. Number one, there was rapid count recovery. The median time to recover neutrophils was only 16 days, and nearly all patients had recovered neutrophils by day 30 post-transplant. Similarly, there was a rapid time to platelet recovery, a median of 26 days, with the majority of patients having recovered their counts by day 60. This compares favorably to the literature. Second notable finding was the overall low risk of acute graft versus host disease. This included an only 3% incidence of severe, that's grade 3 to 4, acute graft versus host disease. These results are similar to what one might expect with an HLA-matched transplant. Thirdly, we also found a low risk of chronic graft versus host disease of only 12% at 1 year. And finally, there was a low risk of non-relapse mortality or transplant-related death of 11% at 6 months. Again, this compares favorably to what's been reported with HLA-matched sibling transplants and also with half-matched transplants in patients who were younger than in this particular cohort. We next examined outcomes according to older age group by decade, meaning 50s versus 60s versus ages 70 to 75, and used patients in their 50s as the baseline comparator. And you can see that the progression-free survival was virtually superimposable, regardless of the age. Similarly, overall survival estimates were superimposable, regardless of age. The numbers below represent the estimates for 2-year progression-free and overall survival, depending on the age category. None of these differences were anywhere near statistically significant. The median follow-up for surviving patients in this analysis is 2.1 years. We next examined outcomes by age group in transplant-related death or non-relapse mortality. And one again surprisingly sees that the curves are superimposable. There is no difference. How did the 27 patients do who are aged 70 to 75? 4 of them had non-relapse deaths, all attributable to infection. 9 have suffered relapse, but over half are alive without relapse and a median follow-up of almost 1 year after the transplant. Could it be that the favorable outcomes in older patients are because they are a better risk cohort in terms of other variables? The answer is no. The one striking difference is the more experience we have doing these transplants, we tend to offer transplants in older patients more recently. That makes sense. But there was no difference in terms of the overall histology of disease. There was no difference in terms of the proportion of patients who had a high-risk comorbidity index. And notably, there was no patient in the age 70 to 75 group who had a low-risk disease risk index. So in conclusion, in this platform of reduced intensity conditioning related haploidentical bone marrow transplant with post-transplantation cyclophosphamide, advanced age does not appear to be associated with prohibitive toxicities if the patient is otherwise suitable for transplant. In fact, we found no apparent decrement in overall outcomes in patients aged 60 or more, or even patients aged 70 to 75, compared to patients aged in their 50s. Next, since many elderly patients may lack a suitable matched SIB donor, particularly because the SIB may also be of advanced age, a haplo option becomes even more attractive because children can be potential donors. And finally, this platform of haploidentical bone marrow transplant with post-transplantation cyclophosphamide appears to have toxicities and outcomes that are similar to what might see in matched bone marrow transplants. Thank you for your attention.